Okay, good evening, everybody. Welcome to this another session of 49th Comprehensive Course in Echocardiography. We have covered to a large extent valvular lesions, including stenotic, regurgitant, prostatic valve as well. So moving on further, today we are going to have a question answer session. Any queries regarding your valves? That's first important thing. Then certain announcement I'll make today at the end of this program so that everybody is there or maybe in the between, because many people they disappear later on at the time when the course is about to finish. So that's what I'm going to do today. And with this, let me just stop sharing the screen and take your questions one by one. You have to raise your hands. And once you raise your hands, I'll be able to pick up each and everybody's name. Anything which you want to know till what we have taught to you. I'll try to demonstrate you all those things. In case I'm not able to, I'll take that work next week and I'm jotting it down, anything which I'm not able to answer today. So let's start with somebody has an apprehension that we are little late. Certainly we are late, no doubt about it. But I'll disclose our strategy at the end of this training session today. So let's start some questions. Anybody would like to ask some questions, please go ahead, because many people had many doubts. They can clear their doubts. Next time you will not get a chance to clear your doubts. One important thing which was told to me by people that they want to learn a revision of aortic stenosis. If you allow me, I can go to the aortic stenosis revision. Salient features. I'm not going to talk you much things, but what all you should look for aortic stenosis, that's what I'm talking about. So if you agree, let me get down to aortic stenosis and give me a second. So just give me a 2 second. And this Xiaomi 11 Night NE, he has not changed at all. Gentlemen, you will remain Chinese ever since.
Sir, I'm changing, sir. Changing. Sorry, sir.
No, you'll become Chinese finally. Like your face will convert as Chinese over a period of time. I don't know why people don't agree with me changing your names and everything. Let me open up my aortic stenosis and so that you have a first-hand idea or revision of aortic stenosis, which was done earlier by Dr. Sanish Shrivastava. He's a very intelligent person. I do not know why did not click in your mind about his teachings. All right, I'm all set with aortic stenosis. So at your level, what is the most important thing is how to assess aortic stenosis. Before than that, I must say these words. We have to identify a subject before he develops these three important symptoms. And all of you must understand and must be knowing definitely effort angina, effort syncope, effort dyspnea. These are the three things which the patient develops. His transition from a stable condition to unstable condition is very fast. Look at the graph. Is almost 90% survival rate and drops down within 1 month or 5 months or 6 months. It is almost down to so that is what is important to identify a subject. Second thing is event-free survival secondary to Doppler gradients. Higher the Doppler gradients, worse is the scenario. Look at the more than 4 meters per second. Look at the graph, 12 months. If I put this line over here, almost 40% of the people have gone. If I look at 24 months, almost 70% people are gone. At the end of 5 years, none is living. So that is what more important for these people to identify their gradients of survivals. And as far as their symptomatology is concerned, NHYA1 versus 3 and 4, almost 28% versus 87%. So we have to look at these people at the level of when they develop, before they develop a symptoms. Correct? Now, this is what aortic stenosis evaluation is. Look at this slide. This slide is almost 20 years old, 2 decades down the line from Mayo Clinic, Rochester. And even today, this slide plays a lot of role in diagnosis of aortic stenosis. What does it talk about? It talks about 4 important things. What are these 4 important things? It talks about morphology, gradients, cardiac output, aortic valve area. And if they're adequate, your diagnosis is already made. If they're inadequate, discrepancy is there, poor output, cardiac output, then we either resort to transesophageal echo, 3D echo, or dobutamine echo or cardiac cath to make a final diagnosis and treatment. So at your level, I'm not asking for many things. At your level is just to look for these important things: morphology, gradients, cardiac output, and aortic valve area. How do we look at M mode, 2D, Doppler data and equations? I'm not concerned about all these for at your level of level 1. Even if you do these 3 important things together, believe my words, you have won the fort as an initial level 1 level. M mode, thickened cusp, eccentric closer line, calcification and reduced cusp separation. Look, this is, if you put an M mode across a aortic valve, this is what the normal aortic valve is: a rectangular shaped aortic valve with a central closing line. It's a very simple basic rocket science. If you happen to see an eccentric closing line, it means possibly you are dealing with bicuspid aortic valve. And if you happen to see this box, which is small in size, it means possibly you are dealing with low output or low cardiac output state. So at your level, don't remember anything. Either you look at this box is small, low cardiac output state. Is a closer line is eccentric, bicuspid aortic valve. And here is an example of bicuspid aortic valve. Look, the eccentric line, it is not in the center. The line is eccentric. So what I've done, I've gone to Platt's view, cut across the aortic valve leaflets, right and non-cornicus. This is right cornicus, this is non-cornicus. Line is not central. If it's central, is not a bicuspid, is eccentric, as seen over here. It is possibly, I'm not saying 100%, possibly abnormal or eccentric line. And whenever we have a bicuspid aortic valve, almost aorta is almost always dilated. Because bicuspid aortic valve is not an aortic valve pathology, it's an aortopathy. Right? Now, these are the 2 things you should look at once you're looking for a 2-dimensional echo. Doming of aortic valve leaflet. Whenever the valve is stuck, what will happen? It will take longer time to open up, and it shows doming as mitral valve. Infective endocarditis, vegetations. Then we look at stroke volume, LVOT diameter, LV hypertrophy, systolic anti-motion of mitral valve leaflet, associated mitral valve disease. Now look at this first finding. Look, this segment is doming in this patient. Look at very carefully. It's doming. It's dome. It's not like this. It's like this. And if you happen to have a doming or stenosis, what you'll find? You'll find turbulence. Look at the scale is 65. Still you find turbulence. Normal scale, what we keep is 50 to 60. Even the scale is high, still I've got a lot of turbulence. What do you mean by turbulence? It means the orifice is small. Now zoomed up. Shall I fix up for you? Yeah. Look, it's doming. So Doming is a feature of stenosis. Eccentric light closure is a feature of bicuspid aortic valve. Then look at this picture very carefully. I hope it plays. No, it's not playing. Well, we have a vegetation out here. So what will happen if you have a vegetation out here? What will happen? It will have a severe aortic regurgitation along with increased flow velocity. Treatment of choice is surgery. Then aging population, dilated aortic root. Look, huge dilated aortic root. Moderate to severe, large regurgitation. Anybody can open your mic. What is the severity of this aortic regurgitation? Somebody open your mic, or I'll start calling you by names.
50%.
50% what? How do you assess the severity of aortic regurg? By regurgitant jet, how will you assess the severity of aortic regurg? We taught you.
Yes.
The moderate, more than one third of the
Where
wing.
do we see LVOT? We are not seeing LVOT over here. It's a vena contracta. This vena contracta is almost 7 millimeter or more. This is severe aortic regurgitation. अरे कल ही तो पढ़ाया था, अभी भूल गए. एक बाबा जी पतंजलि का तेल आता है, डेली शाम को लगाना है. अरे भाई 2 दिन पहले पढ़ाया, अभी से बोलना शुरू कर दिया आप लोग. Now look at bicuspid or tricuspid. This is how we look at a bicuspid or tricuspid aortic valve leaflets. So this is what the bicuspid aortic valve leaflets. Then there is a subaortic stenosis. Subaortic means before the aortic valve, here is a membrane. That is subaortic stenosis. And what you will get in subaortic stenosis? A dynamic LVOT obstruction. You get a Doppler spectrum pattern which is dragger shape. Long exhalation time, sharp deceleration time. And supravalvular. Supravalvular means after the aortic valve leaflets. So the leaflets are over here and the obstruction is over here. So what you'll get, you're not getting turbulence over here, you'll get a turbulence over here. That is supravalvular aortic stenosis. Whether it's sub or supra, diagnosis is important and treatment is only surgical.
Sir, one question.
Go ahead.
Supra subvalvular is depend upon the flow of blood in direction of flow. It is going toward, then that is supra, and below that blood. Is it like that, sir? How to decide?
My neck is aortic valve, below the aortic valve neck is subvalvular. Above the neck is supravalvular. So below the aortic valve is LVOT area. So here is LVOT area, the membrane, subaortic stenosis. If the lesion is distal to the aortic valve in aorta, that is supravalvular aortic stenosis. Clear?
Yes. Thank you.
Hello, sir.
Yeah.
So one question, sir. What is the how to measure the systolic anterior motion and what is its significance in the assessment of aortic stenosis?
SAM is a feature for hypertrophic obstructive cardiomyopathy.
Yes.
I do not have a clip in this, but certainly SAM is a feature for hypertrophic obstructive cardiomyopathy. When we are going to talk about this, we are going to look at this kind of phenomena. Subaortic stenosis and hypertrophic obstructive cardiomyopathy, they have almost the same features. What are the features? They have got a slow acceleration time and sharp deceleration time in the form of dragger shaped of Doppler spectral pattern. In subaortic stenosis, there is a membrane, correct?
Yes.
In hypertrophic cardiomyopathy, what exactly happened? This part becomes more thickened, and during systole, what is the features of hypertrophic cardiomyopathy? There are three important features. Septal posterior wall ratio more than 2:1, asymmetrical septal hypertrophy. Then systolic anterior motion of the mitral leaflet. And third important thing is a dynamic LVOT gradients. So here is a membrane, but if this thickens to almost 2.5 times, so what will happen? LVOT will become smaller. With a contraction of this LV, this valve leaflet is sucked into LVOT. Mitral valve remains opened up, and here we get a gradient, and that gradient looks like this kind of a Doppler spectrum pattern. So what will happen? Here is membrane, here is hypertrophic cardiomyopathy. When this valve is sucked into LVOT, the mitral valve will remain open up, so you get an MR, and here you get a significant turbulence at LVOT. In subaortic stenosis, will not only get a turbulence in LVOT, but there will not be any significant MR. Because here the membrane is acting like an obstruction. Here the leaflet is acting like an obstruction. Clear?
Yes, sir. And sir, one more thing, the doming of the aortic valve we have to see in systole, because in mitral stenosis we see it in diastole.
Yes.
So when the doming occurs in systole, the valves are already juxtaposed to the walls of the aorta. So how to identify that?
Valve leaflet would be restricted, not juxtaposed. Look at the valve leaflet. They are not juxtaposed. They are. Now look, valve is opening up over here.
So when the valve will open, it will be systole. So at that time, we have to see for the doming. No?
Right. In mitral valve, we look for diastole. Here we look for systole.
So why they're looking normal in this clip, no?
Okay.
They are looking comma shapes, like some comma shape instead of.
Hockey shaped.
Hmm.
Now look at this.
Ah.
The leaflet should open straight. Correct?
Okay.
Leaflet is opening like this. Now look carefully both the leaflets. Here is one leaflet. Here is second leaflet. When in normal aortic valve, they'll be opening as straight. That's why this box, which I showed you a few minutes back, look, this is opening straight.
Yes.
Here, this box would be triangular shaped. Okay?
Thank you, sir.
And second thing, if you are not really sure about it, what is the answer is? Look at put a color flow across it. You will get immediate answer. If there is an obstruction, there has to be turbulence. Look what exactly happens when we come out of the picture hall. All people assemble at the exit gate. So many people, they are happening at the exit gate. It means there is a significant amount of turbulence at the exit gate to get out of this picture hall. Same thing happens over here. Here the gate is small, but lot of blood wants to go out of this. Okay. Now this is what is more important. Normal leaflet is tri. This is left cornicus, this is right cornicus, this is non-cornicus. Why we call them left cornicus? Because left coronary artery arises. This is right coronary artery arises. There is no coronary. God has given only 2 coronary arteries. Very selfish. God must have given 3 coronary arteries. Why did they divide the left coronary artery to LAD and circumflex? They could have given a circumflex from here. So we have tricuspid, this is bicuspid, and then we have a unicuspid valves. Now, what exactly we look at this bicuspid or tricuspid? Look, normal, there are three kind of a valves which are seen in practice in bicuspid. One is a left arm opening, like valve leaflet opens like this. Almost 48% of the people are like this. 40% people are like this, and only 4% people are where they look like straighten up valves. So what is the importance? If you happen to have a bicuspid aortic valve, then you may have some amount of stenosis, but that's not significant. And if it's become significant, then you have to replace not the valve, you have to replace the whole aorta. So whether unicuspid or bicuspid, you have to replace the whole of the aorta. So let's move further. The first parameter for looking at aortic stenosis is stroke volume. And let me just call up a name one by one now, because everybody has been enjoying for a long time. So let me look at how much they have been enjoying. So Dr. Avinash Balgir. Avinash, tell me, how do you calculate stroke volume? Avinash? Look, he's not there now. How can we teach somebody to look at an echocardiography? People will log in and they'll disappear and go to practice. He's absent. I'm recording it.
Hello.
Yeah, where were you?
Sorry, sir. No, sir, my mic was not getting on, and last time it was not getting off. Sorry.
So last time it was not getting off, and this time it's not getting on. Something to do with your mic or yourself only? There's some people who sabotaging you in sitting in a clinic. Okay, tell me how to do a stroke volume evaluation. You know, naughty people are remembered very often very correctly. Tell me,
I didn't get
how do you calculate stroke volume?
stroke volume, sir.
Yeah.
Yes, sir. We are LVOT area into VTI.
Okay, how to calculate LVOT?
LVOT area, sir. So we have to take LVOT as a LVOT diameter divided by 2 into pi r square. So R is LVOT divided by 2.
And multiply LVOT VTI. And how do you calculate LVOT VTI?
LVOT VTI, we can do a CW at the LVOT in a sorry.
First part is okay. LVOT diameter divided by 2 into pi r.
Sir, actually in 5-chamber view,
Sir.
we
5-chamber view we go on
a minute, man. Just don't jump and start us talking about it. Let's wait for the time will come when we see who's good.
Yes, sir. We go in a 5-chamber view. We open up the aorta, and at the LVOT we check the PW, and then we calculate auto LVOT VTI, and then multiply it with the area.
Okay, thank you very much. So everybody he has told whatever he has told is correct. Go to Plaque's window, look at an LVOT diameter divided by 2 will give you an LVOT radius multiplied by square it up and pi r square, right? So pi is 3.14 divided by 2, square it up into LVOT VTI. LVOT VTI can be taken either in 3-chamber view or 5-chamber view. Put a sample volume at LVOT, pulse wave sample volume, and that gives you a Doppler spectrum pattern as shown over here. And you trace this Doppler spectrum pattern, you will get a LVOT VTI. So LVOT diameter divided by square it up. This algorithm is not correct. Square it up, multiply by 3.4, and then into LVOT VTI. That give you stroke volume. This is an absolute stroke volume. Divide by body surface area, you will get a stroke volume indexed. Clear? Any questions on this?
So we have to use pulse wave here.
How can you, otherwise, if you put a continuous wave Doppler, it'll take care of a velocity across LVOT and aortic valve. So suppose aortic valve stenosis is present. So you'll not be able to get LVOT with VTI. You'll be getting aortic valve
Analyzing.
VTI because aortic valve VTI is dominant.
Okay.
If you divide this stroke volume by aortic valve VTI, you'll get aortic valve area automatically. Correct?
So in this, we have to take LVOT BTI by continuous wave Doppler.
Pulse wave Doppler.
Pulse wave Doppler.
Site specific at LVOT.
So for getting, sir, aortic valve area, we do not measure aortic valve diameter.
Wait a minute. Let me just go ahead further.
Yes, sir.
Now, look at the Doppler. Same 3-chamber, 5-chamber view. Now you switch on, take your sample volume or a pulse wave from LVOT to aortic valve area. Just cross the aortic valve because LVOT is before the aortic valve, and you cross the aortic valve, go to the aorta, that'll be the aortic valve velocity. So if you have a severe aortic stenosis or aortic stenosis, what will happen? You will not be able to contain the Doppler spectrum pattern despite increasing this scale, moving this baseline up. And that is the time you have to switch on to continuous wave Doppler to contain the Doppler spectrum pattern. Is that clear?
Yes, sir.
So once you look at the Doppler flow pattern by continuous wave, it means you are looking for low velocity across LVOT, aortic valve, through and through all segments across this line. And this aortic valve velocity, you trace this aortic velocity, peak velocity is more than 4. If you trace this mean velocity mean gradient more than 40 millimeters of mercury, and whatever you get a velocity time integral, look, it's 58. Here the velocity is 2.95 peak, mean is 2.14, peak gradient 35, mean gradient 18. So it's not classifying into severe aortic stenosis. Severe aortic stenosis has to be more than 4, more than 40. And this aortic valve velocity VTI, if I go back to my previous slide, this value, whatever the blood which is going through LVOT has to cross aortic valve, correct? So at LVOT, we have got a VTI and LVOT area. In aortic valve, we have got a VTI, but we do not have an aortic valve area. So what do? We divide these volumes by VTI so that we get an aortic valve area. I'll come back to it again. So what did we look? We looked at LVOT VTI. We looked at aortic valve VTI. We looked at aortic LVOT diameter. Then aortic valve area by coordinate equation is LVOT diameter divided by 2, square it up, multiply by 3.414 into LVOT VTI divided by aortic valve VTI, will get aortic valve area by quantity equation. Let me just look at a picture in case I've got. Yeah. Now this is a diagram again more than 25 years old. Whatever the blood which is crossing LVOT has to cross through the aortic valve, which is stenotic. So this aortic valve has got two components, aortic valve VTI and aortic valve area. Here LVOT has got a VTI and LVOT area. We can calculate LVOT area over here by LVOT diameter. And we can calculate aortic LVOT VTI by 3 or 5 chamber view. So whatever the blood is flowing through LVOT, this has to flow through aortic valve as well. We can have this calculation of LVOT area into LVOT VTI, but at aortic valve level, we have got only aortic valve VTI. So if I divide this equation divided by aortic valve VTI, what we'll be getting is aortic valve area. I hope this is clear for all of you.
Yes, sir. But sir, I wanted
Yes,
to
sir.
know,
Clear, sir.
can you not get the area of aortic valve by taking the diameter of aortic valve?
By taking the aortic valve area diameter, what you need to say is again and again is The answer is we do not have a good resolution. What exactly happened? You have a very good answer, like we just go and do a planimetry, correct? By aortic valve area. But when we looked at transthoracic echo to look at that area with our calculation, it was not correlating well. What was correlating well was transesophageal area by planimetry.
Yes, sir. In M mode, sir, across the aortic valve, we get the, sir, aortic valve diameter.
Correct.
So by getting that diameter, can we not get the area?
No. Aortic valve is not a circular area. It's a semicircular area.
Yes.
Let's forget about those things. We cannot. Let's put a line. We cannot.
Okay, sir. Okay, sir.
So what is available today, what is in practical, which is being approved by many people, which is being used in day-to-day practice, this is what the quadratic equation is. Any area less than 1 is considered as severe. Any area more than 1 is considered as progressive. Nothing like mild, moderate, severe. It is either severe or non-severe or progressive. So we saw two important things. We saw stroke volume and we saw aortic valve area. And third thing we saw is a peak gradient and peak velocity and mean gradient. We saw peak velocity and mean gradients. So four things we have seen. You can jot it down on a piece of paper. Once we took an LVOT diameter, LVOT VTI, that'll give you a stroke volume. Then aortic valve VTI, they'll give you a continuity equation. Then aortic valve VTI will give you a peak velocity and the mean gradients. So till now, we have got four factors. So LVOT VTI, aortic valve VTI, LVOT diameter, then aortic valve area by continuity equation will give you any area less than 1 centimeter square is considered as severe. And you divide by this body surface area. This is known as indexed aortic valve area. Look, if my weight is 60 kg, my height is 5 foot 3 inches, my area can be equal to a person whose weight is 100 kg and his height is 6 foot away. So we have to divide this to body surface area by body surface area to get indexed aortic valve area. Normally we consider aortic valve area, we can consider indexed aortic area. Now the most important thing is, let's go back to the equation again. If I don't consider this LVOT diameter, I just look at LVOT VTI, correct? Then second is, I only look at aortic valve VTI. So what is the important thing is, I go to 5-chamber view, just look at LVOT VTI by putting a sample volume at LVOT. That will give me this Doppler spectrum pattern, correct? I calculate LVOT VTI. This is 22.99. Remember this value. I'm going to ask you again. Then I switched over to continuous Doppler in the same format. And I got this Doppler spectrum pattern where the aortic valve VTI is 58.1. That was 22.99, correct? And this is 58.1. So what we have a dimensionless index. What is dimensionless index? You divide LVOT VTI by aortic valve VTI. It means pulse wave VTI divided by aortic valve, continuous wave VTI. So if that ratio is like, this is 22.99, correct? Divided by 58.1, it is 0.39. And if this ratio is less than 0.25, that's the next segment. If ratio is less than 0.25, we consider it as severe aortic stenosis. Clear or not clear?
Sir, LVOT VTI divided
Yes,
by aortic valve VTI is less than
0.25.
0.25.
Right in front of you.
0.25. Yes. Okay, sir. Okay.
These 5 parameters, if you do these 5 parameters, your aortic valve is area less than 1, severe. If area is more than 1, non-severe. Peak velocity less than 4, more than 4, severe. Less than 4, non-severe. Peak gradient more than 40, severe. Less than 40, non-severe. Dimensional index 0.25, less than that, severe. More than that is non-severe.
That
इतना
means, sir,
बहुत है. आपके लेवल के लिए बहुत है इतना. Only fact is you have to look at the peak velocity and gradients.
So how to calculate the index aortic valve area?
Whatever the aortic valve area is, divided by body surface area. How to calculate body surface area? Just put on a machine. Go to the machine, put height and weight. It will give you body surface area.
Okay. Thank you, sir.
So remember these very few important things for calculating aortic stenosis. Nothing more. It's not a rocket science. Are we clear on this or not?
Yes, sir.
Clear,
Okay,
sir.
sir.
Don't say yes. Anybody who has got a problem, open your mic and say yes. I've got a problem.
Where is the cursor on LVOT and AVBTI?
Wonderful.
Sir, same question, sir. Where
Okay.
you put the cursor?
Are you
And
comfortable
what
with this? I'll stop this presentation. I'll go somewhere else now. I'm just trying to open some formats. It's taking time to open up. Let me just show you where to put a cursor. Now, can you see this three-chamber view?
Yes, sir.
Nobody, yes.
Yes, sir. Yes, sir.
So this is, let me just freeze this image. So this is LA, this is LV, this is aorta, correct? And here's the aortic valve leaflets. Clear? If I put my sample volume, pulse wave sample volume over here, it will be a pulse wave LVOT. If I take this sample volume to distal to aortic valve, it will be pulse wave at aortic valve. What exactly happens? When there is a stenotic, this is a pulse wave Doppler spectrum pattern is, look how much is the scale. 3 on this side, 1 on top. So maximum is 4 is contained with. Suppose my velocity is 5 meters per second. This, if I move this baseline up, I'll not be able to contain this Doppler spectral pattern. So what do? We switch over to continuous wave Doppler. Correct? Pulse wave over here and continuous wave Doppler over here across it. Pulse wave will give me LVOT VTI and continuous wave will give me a aortic valve VTI. Just remember this thing.
Sir, any specific distance in the aortic aorta we have to look for aortic valve BTA? Below the aortic valves?
Below the aortic valve is LVOT. Through the aorta is aortic valve VTI.
Yeah, in the aorta at what distance from the valve tip?
Any aorta, just cross distal to the leaflets.
Okay. Thank you, sir.
Sir, it is CW or PW?
CW.
CW.
LVOT, PW, and aortic CW.
Correct.
CW. Oh, thank you.
Dr. Gunjan.
Sir, please repeat once. I'm little bit confused with this PW and pulse wave Doppler and color wave Doppler at LVOT and this
Remember, one important thing is pulse wave is a site specific. Suppose I keep my pulse wave over here, so I'll be measuring velocity only at this point, at the level of LVOT. Correct?
right.
If I put a pulse wave at the aortic valve level, I'll be measuring aortic valve velocity at this level.
Yes, right.
In circumstances, my velocity is 1.7 meters per second. But in aortic stenosis, my velocity goes up very high. When we were teaching with the basics, we were saying, if you have a stenotic lesion, then you're looking for site specific. You are using continuous wave Doppler to look for the maximum velocity.
Okay.
So in normal circumstances, if I keep it over here, LVOT, or keep it aortic valve, they will be almost same.
Yeah.
But
So,
in aortic stenosis, LVOT velocity will be low. But distal to aorta or aortic valve velocity would be very high. That will not be contained in this Doppler spectrum pattern. By pulse wave, it will produce aliasing. So for correcting aliasing, we move the baseline in an upward direction so that the Doppler spectrum pattern is contained. If not contained, when you switch over to continuous wave Dopplers. Continuous wave Doppler will do what? It will take the velocity at the aortic valve level, it will take the velocity of LVOT, and whole of this line, it will take the velocities. But it gives the maximum velocity at the aortic valve level. Correct?
if yeah, that I understood. But as there will be a stenotic lesion, so there will be a turbulence, right? Then why there will be at the level of LVOT? Why we will not take with the color with this CW only?
Suppose you take a CW over here. What do you mean by CW? Is continuous wave Doppler. Continuous wave Doppler will measure velocity across whole of this line. So if it measure velocity
along the LVOT, yeah.
So it not measure at LVOT. This LVOT velocity will be submerged in aortic valve velocity.
Okay.
Okay, now look at, now you got the answer. I'll give you better answer. Look at this Doppler spectrum pattern over here. Can you see this Doppler spectrum pattern over here?
Yeah.
Look at this spectrum over here. What is the spectrum?
Sharp down.
Over here.
Look.
This small spectrum pattern seen over here is this one. Can you see this?
Turbulence.
Oh, there are two Doppler spectrum patterns, one in each other. One is over here, one is over here. Now this velocity is almost 1 meter per second. Correct?
There is a LVOT, sir.
This is LVOT. Let's go back and see LVOT velocity. This LVOT velocity is almost 1 meter per second.
Okay.
So if you measure the continuous wave Doppler for LVOT velocity, this pattern would be submerged in a Doppler flow pattern of aortic stenosis. And that you will not be able to identify. Look, you can see over here, but you can't see over here. So pulse wave at LVOT, continuous wave at aortic valve.
Pulse wave at LVOT and continuous wave at
aortic valve.
Aortic.
Sir, only in case of aortic stenosis.
Only in case of aortic stenosis. If it's a normal circumstances there, even if pulse a pulse wave or a continuous wave Doppler, it will be almost same. Because there's no stenosis. Whatever the blood is going through LVOT has to pass through the aortic valve.
Sir, means it pulse.
Doors are wide open. Go ahead, go ahead.
Sir, if your aortic valve is normal, then you can use a pulse wave both at side.
You can. You should. You should use it. Are we clear now?
Yes, sir.
Janvi. Somebody was, Janvi wanted to ask something.
That is for a different issue. I want to ask about this, sir, how to calculate stroke volume by using mitral wall blood flow. That is later on also you can, not once AS is over.
Okay, I'll tell you right now, while later on. Give me a second, let me go to some 4-chamber view.
Excuse me, sir.
Yeah.
Sir, whenever there is associated AR, same criteria will be applied for the severity grading of aortic stenosis?
Yes, AR. Same criteria. ASMR, it will be a difficult problem.
Okay.
Because AS with MR will really be a trickle job, you know.
Okay.
ASAR is whatever the blood which is flowing, going back to LVOT, to LV, which has to come back through LVOT and aortic valve.
Yes.
But in aortic mitral regurgitation, lot of blood will go out. So we are not talking of multivalvular lesions at this present moment. Please. That's a different ball game altogether.
Okay, sir.
Yeah, okay. She wanted to ask how to calculate mitral valve stroke volume. Go to 4-chamber view, look at this hinge point, join them together during diastole. They'll give you the radius. Divide by 2, give you this will give you diameter. Divide by 2 will give you radius. Pi r square will give you area. Then do a Doppler spectrum pattern by pulse wave across mitral valve. Trace that up, they'll get a VTI. They'll get stroke volume across mitral valve. Is that clear, Dr. Chanvi?
Yes.
Sir, please repeat.
Oh.
Can you please repeat? Yeah. I was also confused with it, what ma'am has asked. Please slowly.
Okay, I'll do that. Look, freeze this frame during diastole. So I'm trying to freezing this frame during diastole. Oh.
Okay.
So mitral valve is open, just open up.
So
Yes.
diastole also is a long phase, no, sir? Which part of diastole?
Just opened up. Mitral valve is opened up.
Mid.
Okay, mitral valve is opened up. Okay, they are about to open up, and I say yeah. So one hinge point to second hinge point will give you diameter.
Yes.
Diameter divided by 2 will give you radius.
Radius.
Pi r square will give you area. R is radius. Pi is 3.14. Square of radius into 3.14 will give you area. Then put a Doppler spectrum pattern of pulse wave across mitral valve. Trace the Doppler spectrum envelope. You will get VTI. Pi r square, that is area into VTI, will give you stroke volume.
Yes, sir.
When there is a AS and there is a MR, then this two will be required, no, sir? Stroke volume at mitral wall and I suppose.
No, we'll not be doing this. If I get an AS with MR, I'll just put a transesophageal probe inside and look at the planimetry area.
Thank you, sir.
Okay, so let's move further in aortic stenosis. Problem with aortic stenosis is these three leaflets, they are nuts. Why they are nuts? Look at these three leaflets.
Sir, I have one question. Can we use planimetry area in and VTI for calculating the stroke volume?
If you calculate a planimetry area, why do you want a stroke volume then? Okay, I'll just show you this picture. Look at this is transthoracic aortic valve area which I'm trying to calculate over here. How fuzzy the lines are. And these lines, this area do not match with the aortic valve area when we do a surgery. If I do a transesophageal echocardiography, my calculation of aortic valve area is extremely perfect. Let me now go to transesophageal. Give me a second.
Sir, probably he wanted to ask the mitral valve area by planimetry for the calculation of mitral valve stroke volume.
If you have got a material area, why do you want to go planimetry?
No, sir, it was the annular area we used, no, in the calculation of stroke volume.
Yes.
And planimetry, we take the valvular area.
And so annular area is just to get a stroke volume.
Yes.
If you want to get a material area, just go to planimetry.
No, the probably question was to the valvular area, can it be used for the calculation of stroke volume?
No. Reverse.
In mitral valve stroke volume.
No, it's not possible.
Okay.
तुम तो यार पूरा मेरे को लगता है थोड़े दिनों के बाद मेडिकल साइंस को रिवर्ट कर दोगे आप.
Sir, in case of AF, it will be varying, na, sir?
AF, what will be?
Metal VTI will be varying, na?
Yes, mitral VTI will be varying. So, mitral VTI would definitely vary with every atrial fibrillation patient, no doubt about it.
So, we have to average it?
Average 11 beats.
11 beats.
Okay. So, this is a 56 number. So, let me just share with you this transesophageal area 56, slide number 56. Yes. Now look at this. Let me just freeze this image for you. Look how beautifully you can see this aortic valve margins in transesophageal echo. Can you?
Yes.
Yes.
So whenever we are in doubt, we do not look at other things. We just put a transesophageal probe inside and look at the aortic valve area. And this resolution, this imaging quality is not there in transthoracic echo. Maybe like what I'm talking is 10 years down the whole line, 10 years down the line. Maybe like today, the resolution has gone up much better, which was there earlier. Maybe there's no study now which is talk of this. This could be one topic where we can look at this aortic valve area by transthoracic, but we have to do all transesophageal echoes in that case.
Is it still stenotic, sir?
No, it's normal.
This wall? No.
Normal. The resolution is so good that it looks to be like thickened, little bit thickened. Okay. So this is what is aortic.
Hey.
Now let's get back to aortic stenosis again. The problem with aortic stenosis, it's really a nut. Why it's not is a nut is because the problem is we have three leaflets of the aortic valve leaflets. Right, left, right, and non-coronary cusps. Now, how do you say which this is known as raphase 1, 2, and 3. Some stenosis happens. How do you say these two raphase, this raphase involved, this raphase involved, this raphase involved, all three of them are involved? How do we say that? We have no answers. So if based on this, we do not know where the jet would be. If these are involved, jet could be somewhere else. If this is involved, jet could be somewhere else. If this is involved, jet could be somewhere else. Something like a pipe of a water, if you have used sometimes while watering in the garden, while using a pipe in the garden, suppose you pinch on this side, the jet would go on this side. Suppose you pinch on this side, the jet would go on this side. Suppose you pinch on both the sides, the jet will go on this side. So how do you know the way the jet is going? And that is the most important problem for this aortic stenosis. So what we do in aortic stenosis is we don't limit to only one window. We look at 6 different windows. One is apical 3-chamber view, apical 5-chamber view, right parasternal window, suprasternal window, subcostal window, and this is what we have devised ourselves is right anterior oblique view by Jra. And wherever we get the maximum gradient, LVOT, VTI, you can take in 3 or 5-chamber view. But the peak gradient, peak velocity, peak VTI, you have to take the maximum amongst all these 6 different windows. So that is the reason when we get an aortic stenosis patient, we take almost 1 hour. Got it? Clear?
So you, which window will be best, sir?
All windows are good.
Just according to you.
That's what I said. It depends which side of the pipe is pinched. I showed you that picture. Suppose my pipe is pinched over here. My jet would be on this side. अभी कभी गार्डन में पानी दिया है नहीं दिया है?
Yes, sir.
दिया है ना? और नहीं दिया तो कल सुबह जाके देना है.
दिया है सर.
पिंच करके देखना कि जेट कहाँ जा रहा है. फिर ये वाला पिंच करके देखना जेट कहाँ जाना है. फिर दोनों साइड से पिंच करके देखना कि जेट कहाँ जा रहा है. सो अगर मैं इसको पिंच करूंगा तो मेरा जेट इधर जा रहा है. इसको पिंच करूंगा तो मेरा जेट इधर जा रहा है. इसको पिंच करूंगा तो इधर जेट जा रहा है. तो आई हैव टू गेट द मैक्सिमम जेट, and that maximum jet I get through these 6 different windows. All of you are very aware of 3-chamber, 5-chamber, right parasternal, suprasternal, subcostal windows. Only thing is right anterior oblique view. So at your level, remember 5 and keep guessing about 6th. All right?
Sir, explain right anterior oblique view, drop view again.
Right anterior oblique view is a modification of a modification of suprasternal window, where we keep a probe in suprasternal window, but we keep a pillow behind the right shoulder. So if you focus my image over here, we'll be looking like this, like we'll be looking like this. So my neck is extended on the other side, and my suprasternal window is there, and my right shoulder is behind the pillow. So what I'm doing is, I'm bringing more of an aorta in the front.
Okay.
And it came by surprise, like one day the patient was not putting a pillow behind the shoulder, he was just putting the pillow again and again behind the right shoulder. And we found it to be very useful, that window. Ever since that, we always use that window. Somebody asked this question, which is the best window? Believe my words, majority of time we are getting a very good gradient in 5-chamber view, right parasternal region, and then is right anterior oblique view. So we spend time normally. It's really a time job.
Sir, can you please explain the right parasternal view again?
Right parasternal window is like lie down on the right hand side. Put a probe on the right side of the chest, right third intercostal space, index mark facing towards 12 or 1 o'clock.
Okay.
So I'm done with the aortic valve. Anything somebody would like to ask about aortic valve?
Sir, sometimes there is wall is bicuspid, but in diastole, it will appear like a 3 rapids.
Always look in the opening of the valve, not the closing of the valve.
Yeah.
Closing will look like same.
Same.
It's the opened valve which looks like bicuspid or tricuspid. I was trying to look for an image. Just give me a second. I made something new presentation recently and I'm not able to get that image out here. Let me just close down this image. I was talking about what? Aortic regurgitations of mitral. Give me a second. I'll show you that particular image, what you are asking for. I was trying to explain what exactly this working is. Aortic. अभी नहीं हुई.
It is thick and calcified, then it will be difficult, sir, whether it is the bicuspid or not.
Your aortic valve lesions are thick and calcified. So how can you see a aortic valve area in those thick and calcified lesions?
Transesophageal.
Yeah, even transesophageal is not helpful at that time.
Sir, in aortic stenosis, along with one patient is there today, I screened. She had a pacemaker and she had a severe tricuspid regurgitation. And I found on the gradient basis aortic stenosis also. On the M mode, she had that sawtooth appearance on that aortic box. But I was not able to get the aortic regurgitation jet.
Aortic regurgitation. Sawtooth appearance is aortic regurgitation.
Achha, so we have to consider it as she has a AR.
Right.
I have to again screen for the AR jet. Okay. Thank you, sir.
Every image tells you something. Believe my words, every image tells you something.
Yes, sir.
So where is was just second, I'm not able to see. Give me a second. I'm just trying to find out the image, which was very useful image was there.
Sorry to disturb you in
No,
between, but
no,
sir,
sorry.
सर मैं कहना चाहता हूँ आप कितनी मेहनत करते हैं सिखाने के लिए मैं सोच नहीं सकता.
अरे फिर भी आप सीखते नहीं हो यार.
सर कोशिश तो पूरी कर रहे हैं.
कहीं नहीं करते यार, आप लोग कहाँ कोशिश करते हो.
थैंक्स अ लॉट सर. थैंक्स.
अगर आप सीख जाओगे तो मेरे को सबसे बड़ा बेनिफिट मेरा होगा लाइफ में.
सर सीख बिल्कुल सर, बिल्कुल कोशिश कर रहे हैं सर पूरी.
You know, like when I came back from US in 1991, I went to Churu, small tinsel town in Rajasthan.
हाँ सर.
And the guy was a filthy rich person. He was lying in a bed with interval MI. So asked the family, can we get an ECG machine? So there was no ECG machine in Churu at the time, 1996.
Yes.
Unfortunately, asked another big question. Do we get happens? There was no happens. So they went all the way to Luharu to get low molecular heparin, which is about 60 kilometers away from Churu. And that man was a multi-billionaire. His room was where he was lying, was a glass room where there was no light. Only thing was about 8 candles. And the illumination was extreme.
Oh.
And when we got him to Delhi at that time, he was having anterior MI with almost akinetic LED. Dead LED. Obviously, what we could do, we did a bypass and everything. And I had just come back from US at the time, 1991. And you know, like getting an echo machine during that time in Delhi was also a few places we used to have an echo machine. One place was Gangaram, Fortis Escorts, and one Divanchand Nursing Home, Divanchand X-ray Clinic and Plot Place, and Shamla Nursing Home in Daryaganj. There were 4 machines available at the time. So now Churu has got a machines, everything is there. It's not a question that Churu cannot afford it, Churu is not there. The issue is like whatever we are teaching should be utilized for clinical purpose of human mankind.
Yes, sir.
That's all I wanted to say.
Yes, sir.
And if you learn
Yes.
these kind of things, ultimately who will get benefited? The community will get benefit. I don't know, like, how do you
Yes.
take your life? I say our life is devoted to our community.
Yes.
Definitely. Definitely.
Correct, sir.
I don't know what you people, like many people have must read in private medical college, but I have read in a government medical college where my annual fee was only 300 rupees. 73 to 79. And I used to get a stipend of internship was 288 rupees.
Oh.
So when the government has given so much to us, is our time to repay back to them.
Yes.
That's only answer. And if you happen to diagnose even one subject tomorrow, in whole of your 1 month with the help of echocardiography, I think your job is done already.
Yes, sir.
So let's go and ask some questions more. We are lagging behind, and only like today, look, many people have disappeared. Only 47 are there out of 85.
Sir, what is the normal aortic valve velocity and what is the gradings of aortic stenosis?
Normal aortic valve velocity is 1.7 meters per second, maximum. Remember two velocity. One is 1.7, that's maximum of aortic. 1.3 is the maximum of mitral valve. Half of aortic is tricuspid, and half of aortic is pulmonic. Half of mitral is tricuspid. Remember 1.7, 1.3. That's all you need.
Half of aortic is tricuspid.
Half of aortic is pulmonic.
Half of aortic is pulmonic. And is there any grading of aortic stenosis on the basis of velocity?
People used to call a mild, moderate, and severe aortic stenosis earlier. Now they are not calling it anymore. They say just severe aortic stenosis or progressive aortic stenosis. Older population, they still call it just like mild, moderate, and severe.
Okay. So aortic valve area we see the gradient and the dimensions less number for calling it.
I made you remember 5 important things: stroke volume into LVOT VTI divided by aortic valve VTI will give you aortic valve area by quadrant equation. That
is one thing. Yes.
Second important thing is peak velocity more than 4 meters per second by continuous Doppler.
So that will only tell us about severity.
Severity more than 4, severe. Third important thing is mean gradient more than 40 millimeters of mercury.
Okay.
Severe. Fourth is dimensionless index.
Less than 0.25.
0.25 or less. Severe.
Yeah. So these 4 things we have to remember.
Yeah. And whenever you have a severe aortic stenosis, what will happen to LV?
Hypertrophy.
Hypertrophy.
If you find an hypertrophy, think twice what you're looking at.
Thank you, sir.
I've got a recording where patient has a severe aortic stenosis, but no LVH. At your level, think twice. Okay? Questions? More?
She was telling now about the sawtooth, sir. What is that sawtooth? We saw something in ECG for.
Sawtooth is a manifestation of aortic regurgitation.
Which tracing, sir? Which tracing? In
M mode aortic box.
M mode. I'll just show you M mode. Give me a second. There is so much to read every day. And believe my words, if you read, you do something wonder in your area. We have virtually forgotten M modes over a period of time, you know.
Sir, do you recommend any book for entry level echocardiography? Textbook?
How to read books, man. Listen to these talks again and again.
Okay, sir. Thank you, sir.
These talks are more than enough to learn every day, man.
Read the book sent by Job Institute.
Yeah, read that book sent by Europe Institute. I'm improving that books over a period of time.
Sir, in the evaluation of every valve, I was reading in the book, the morphology, Doppler, and the Doppler calculations. Are these three things enough for evaluation of all the valves?
Say it again.
Morphology, Doppler, and Doppler calculations. Morphology,
What is
function,
left?
Doppler.
What is left?
So that's what I'm asking. Are these things same for all the valves?
More than enough. More than enough.
So it was given functional evaluation. Functional evaluation is done by Doppler only.
Right.
Thank you.
Sir, kindly explain, sir, low flow, low gradient. Yes, sir.
I deliberately left that topic and you want to touch it again now? Okay, I'll just show you. Give me a second.
Yes, sir. Yes.
Sir, also about paradoxical.
What is that?
Low flow, low gradient, paradoxical.
Same thing. Okay. So what she was asking is just copy.
That is
Sawtooth experience, correct?
Yes.
Just give me a second. Like, there's so much of a data, like you have to look.
Sir, I shared the image on the group.
You shared the image already?
On the group.
Okay.
Just check it whether it is correct.
Can you see this now? This is M mode across mitral valve level. So this is diastole, this is E wave, this is A wave, correct? When during diastole, the mitral valve opens and there's a AR jet is present. AR jet will strike across mitral valve. So it produces sawtooth kind of an appearance. Look, this is sawtooth. Sawtooth is like Hindi भाषा में क्या कहते हैं? आरी. So look at this sawtooth kind of an appearance.
Yes.
Fluttering of AML. Look, this is AML. This is not PML. PML is over here. PML is over here. So this PML will go down. AML will go up. So this AML will be affected by AR jet. So you get fluttering of AML. So this sawtooth kind of, this is very critically seen over here. Look, this is, if I really zoom this image to still bigger one. Uh-oh. Look at this fluttering. This is sawtooth appearance. Clear?
So the cursor should be at the mitral valve and not the aortic valves.
If the aortic valve cursor would be how aortic valve is regurgitation jet is producing this sawtooth experience.
The sawtooth of the anterior mitral leaflet.
Correct.
Thank you.
Anterior mitral leaflet.
AML fluttering. And is only present when the jet is striking back towards AML. It can go towards interventricular septum also. The problem with aortic valve is it could be eccentric. It's like a boy, a rotten boy in a class.
Sir, then when in the aortic cusp, that box also we see the sawtooth appearance, then what is that?
Aortic box, we see a sawtooth experience.
Appearance, yes. 2-3 patient I had noticed.
Aortic,
My colleague said ki it's a because of air.
aortic box sawtooth experience. Just let me
Aortic, that cusp, square we see, na?
Yes, I got it. Let me just square, let me sawtooth experience. I'll have to see for it. Okay, let me stop over here, this presentation.
Yes.
Sir, in case of AR associated with MS, can we calculate the mitral valve area with the pressure half time, or it is not visible, sir?
Both the things are positive. It could be overestimated, underestimated. If the jet is striking over the mitral valve area, mitral valve leaflets, it will be overestimated. If the jet is away from the mitral valve leaflet, it will be underestimated.
Okay.
If it's center, it will not make any difference. So both the things can be possible with MS with AR. So if you have MS with AR, I'm not going to put my bets on pressure half time. Whatever the condition is, I'm going to put a bet on mitral area by planimetry. So somebody wanted to ask those low flow, low gradient. I did not deliberately touch the topic because it's not at your level, but let me just tell you.
May miss the severe AS when there is a cardiac output is less.
Okay. This is slide number 66. Now see the classification of severe aortic stenosis. This is what is normally seen. Peak velocity more than 4, mean gradient more than 40, aortic area less than 1, index less than 0.6, stroke volume more than 35. This is normal flow. This is normal flow is more than 35. High gradient more than 4 and 40. Clear? Then next variety is normal flow, but low gradient. Now the gradients have reversed. Less than 4 meters, less than 40 millimeters of mercury. Aortic valve area and next aortic valve area, all they remain the same. Third variety is low flow, low gradient, severe aortic stenosis. Here the area is less than 1, index is less than 0.6. Stroke volume, low flow, less than 35. Gradients are less than 4, less than 40 millimeters of mercury. So normal flow, high gradient, normal flow, low gradient, low flow, low gradient, and this is known as paradoxical aortic stenosis. If you look at very carefully, what exactly is happening? This is a continuum of the sequence of evolution of aortic stenosis. Aortic stenosis is maturing from normal flow high gradient to normal flow low gradient. When the LV cavity becomes really thick, so what will happen? It starts generating less of a force. So the gradient will start falling down. Now the LV cavity is still more thick. The volume decreases. My cavity is like this. Now it becomes really thick and the inside volume becomes still smaller in size. So what will happen? The output would be low. So if you really ask me, this patient is normal flow high gradient is much better than as compared to low flow low gradient paradoxical aortic stenosis. This is more dangerous a variety because it's a continuum of disease from the normal flow high gradient, normal flow low gradient, and low flow low gradient paradoxical aortic stenosis. And worst, when all these things have a normal LV systolic function, ejection fraction is like in paper says 54%, but I don't agree because 54% is like somebody has got a 60% ejection fraction has fallen down to 54. Now we say normal, but it's not normal because earlier the ejection fraction is more than 66, 60%. So guideline says more than 50% or 54%. But I feel the ejection fraction should be at least 60% in aortic stenosis to talk them as normal LV systolic function. Here the ejection fraction is even less than 54%. So what will exactly happen? Aortic valve area is less than 1, index area is less than 1, stroke volume is less than 35, gradients are low, but even LV function is poor. So what we give, we give low dose dobutamine. Low dose means which increases the cardiac contractility less than 10 mics per kg body weight. We start from 2.5, go to 5, go to 7.5 and maximum 10. Heart rate should not increase, only the force of cardiac contraction should increase. If you give a low dose dobutamine, the gradients will go up and the area will come down. And this is known as true aortic stenosis in this variety. If the gradient goes up and the area goes up, that will be known as pseudo aortic stenosis. So this is what is available as on today.
So what is paradoxical here, sir?
Paradoxical means gradients are low, but aortic valve area is less than 1.
Oh.
Paradox means severe aortic stenosis is present, but the gradients are not there. And this is really fooling. Why it's fooling is because you do not know whether this patient has got a severe aortic stenosis or not.
So can the case of AR with AS have low flow, low gradient paradoxical aortic stenosis?
AS with AR, anyone could be possible.
Because in long term, because of AR, there will be dilatation of the left ventricular cavity.
LV function, the function will go down.
Yes, that's
it could be possible.
But the volumes are increased, so will they cause high gradients?
Volumes will not increase the gradients.
Pressures will.
Volume will always increase the peak gradients, not the mean.
Okay. So in the criteria, we have the mean gradient.
Mean gradient. Look at the, I never said peak gradient. I said mean gradient. Average of all instantaneous gradients. You just trace the Doppler spectrum pattern, will give you peak velocity, peak gradient, mean velocity, mean gradients.
Low flow, low gradient suggests left ventricular failure.
Low flow, low gradient.
In aortic stenosis.
There are two kinds of a low flow, low gradient. One is with normal LV systolic function, one with poor LV systolic function. With normal LV systolic function is where LV function is normal, that is paradoxical aortic stenosis. Where LV function is poor, then we have to decide whether true or pseudo aortic stenosis.
So with a normal LV systolic function, low flow, low gradient aortic stenosis, is it worse than the normal flow high gradient?
Correct. You think of yourself. I said the same thing. In normal flow high gradient, what exactly is happening? The function is very good. It is able to generate the forces. It is able to give out a good amount of output. Now the second stage is function is good. Is able to give a good output. But it just start losing the gradients. Generation of gradient is gone. Like it's like think of a horse or think of yourself. What exactly happens when you start working in the morning? You are full of energy. You are normal flow high gradient. By afternoon, you become still good of energy. Your output is good, but your speed has reduced a little bit. The velocity and gradients have reduced a little bit. And by evening, you become paradoxical. You are good of energy, but your output, your stroke volume, your output is start dwindling over a period of time. And at this point, if somebody asks you to do something which you are not expecting, you start getting irritated. But this will not happen in the morning time. So this is a continuum of illness from this stage to this and from this stage to this.
So by flow, we mean volume.
Well,
Thank you, sir.
But without any ischemia, can there be a poor LV function, sir? Or it may be because of coronaries are involved and therefore there is a poor LV function.
the coronaries are involved, we'll have a wall motion abnormalities. Look, most important thing is what you're talking about is if somebody develops an illness in the sense people, what exactly happens? Now think of it. My heart has worked with the Starling law. Correct? So if this some obstruction is there, what will happen over a period of time? Heart has to work harder to deal with the obstruction.
Yes,
so
sir.
when I'm dealing harder with an obstruction, a time will come when I'll start failing. My LV will start failing. And that LV, that's what exactly I said. My ejection fraction in aortic stenosis should be what? 54, 55?
Yes.
No, my ejection fraction has to be 66.
It has to increase, sir, than normal. But it is hypertrophied also, no? So it can increase it.
So increases. But ejection fraction in this low flow, low gradient drops down significantly, but still within normal limits.
Yes.
And how do we look at this low flow, low gradients? I didn't want to go further. Let me go further now. So there are two ways looking at a calcium scoring and looking at the GLS. So what will happen? We start looking for a global longitudinal strain. Normal is -20. So then this low flow, low gradient severe aortic stenosis, this tells you a subclinical LV dysfunction. So my GLS would be low. Oh, you got the planimetry of aortic valve area over here. Now you can see where I was looking at somewhere else. You can really planimetrize the aortic valve area. So we do a GLS in this subset of population. If the GLS is low, obviously we consider that patient has got a subclinical LV dysfunction. GLS is below.
GLS is global LV.
Global longitudinal strain. Not at your level again. Just forget about it. You'll get mad on aortic stenosis. Aortic stenosis and diastology, they themselves are two big topic of echocardiography. Ever evolving.
Okay.
Dr. Baljit Kaur, Sehra, go ahead.
Sir, just to change the topic, sir, I wanted to ask, sir, about PISA method in MR, sir. Can you please elaborate it for regurgitant orifice area?
Okay. Just give me a second. Slide number 100. Okay. Can you see the slides?
Yes,
Yes,
sir.
sir.
Okay. Now look at this severe mitral regurgitation. If I hold this slide, okay. Now this is a severe MR, right? What do you see over here? You see a multiple hemispheres. Correct?
Yes, sir.
And the best answer is tomorrow you take a bucket of water, put it in your wash basin. As soon as you'll put a water in the wash basin, you'll hear a gurgling sound and you'll see a multiple hemisphere of a water, water which is draining into the pipe. And these hemispheres, this is one direction, it's two dimensions. So we are just cutting a slice across it. So what we do, we take a radius of these hemispheres. So from this point to this point, that is the radius of this hemisphere. Right? Now let's do it. What exactly we do it? So first of all, when we see a severe mitral regurgitation, we move this baseline towards downside in the direction of jet. So this will become 80 to 100 and this will become 20 to 40. So I'll move this scale down. There's a button on the line, like where you move this line down. So what will happen as you'll move this line down, these hemispheres become much clearer and bigger in size. Like they give you a real value to look at these hemispheres. So we move this baseline down. So this is another velocity of aliasing. So look at this. This scale has gone down and this is the all velocity of aliasing. This is the area and this is radius. So regurgitation volume is 2 pi r square, 2 into 3.14 into r square. R square is that radius into velocity of aliasing. This is velocity of aliasing in centimeter per second. So whatever we are taking should be in one single frame. 2 pi r square means r is centimeters. So 0.5 into 0.5 into 20 centimeters. That'll give you regurgitation volumes. Now you have to get effective regurgitation orifice area. So regurgitation flow divided by peak velocity of MR jet in meters per second. And that'll give you effective regurgitation orifice area. And this effective regurgitation orifice area is, if it's more than 0.3, we call them as severe mitral regurgitation. But the problem is, how many calculations are there? One is radius, second is velocity of aliasing, and third is the MR jet. So we have a chances of having wrong calculation at 3 different points. Right?
Yes, sir.
Last part, sir, please. Last line. Once again, repeat, sir, please.
Pi r square into velocity of aliasing. So 2 pi is 3.14. Radius is, this is radius. This is velocity of aliasing. Effective regurgitation orifice area is regurgitation flow divided by peak velocity. Here is a peak velocity in meters per second. If it's more than 0.3, is considered as severe mitral regurgitation.
How do we get velocity of aliasing?
Velocity of aliasing, MR jet. Velocity of aliasing is this. Nyquist limit. We move this Nyquist. Look, this is not the scale which we use regularly. 62, 62. Here this is 100 and this is only 20. So velocity of aliasing would be 20. Whatever this value is seen over here, there will be velocity of aliasing.
So value would be seen
in the machine.
when we load
Look
it
at
down.
this machine, 62 is the velocity of aliasing over here. But this line has to be moved down to make a clearer this radius of the pizza.
So it is subjective.
Subjective. No, you have to change it accordingly, no? Because to make this clear, we have to make this baseline down.
Something that is clearer for me might not be clearer for you.
Just hold on for a second. So it's subjective in the sense how much you move it down. That could be one possible answer. But my quest is forget about all these things. Look at a direct method of looking at regression volume. What you are getting finally over here is, if I go a step further, what I am doing is effective regression orifice area into mitral regression VTI now. Another calculation. So I'm getting a regression volumes. But in case you really want to have a regression volume, is why you're putting so much emphasis on this? Why not still directly go to regression volumes? Look at the LVOT VTI, look at a stroke volume across LVOT, look at the stroke volume at mitral valve. If the stroke volume, what will happen to the stroke volume aortic valve, LVOT? If there is a severe MR, what will happen to the stroke volume of LVOT?
It will increase.
Increase or decrease?
Decrease.
It will lot of blood is going back into mitral valve.
Increase.
So if I take this LVOT stroke volume, LVOT diameter, I told you already this. So if I measure my LVOT stroke volume, I measure my LVOT mitral valve stroke volume. Mitral valve stroke volume minus LVOT stroke volume, my regression volumes. And it's more than 60 ml is considered as severe. If I echocardiography today. Look, there are 10 methods of calculating the severity of MR. At your level, remember what have been talked to you. Don't get into PISA, because PISA gives you a very erroneous value number of times because of number of values which are to be calculated. Very simple method, which I always say recommend is look at this velocity integral ratio across mitral and aortic valve. I told you a dimensionless index of aortic valve, aortic stenosis. This is a dimensionless index of mitral regurgitation. Mitral aortic velocity integral ratio. Look at the mitral valve velocity, mitral valve VTI. Look at the aortic valve VTI. Divide mitral valve VTI by aortic valve VTI, what you get of a ratio, if it's more than 1.3, is considered to be severe. That was 0.25, here is 1.3. And it is really correlated well with PISA. Think of a simple thing at this time to learn.
Yes.
Mitral valve VTI versus aortic valve VTI. If there is a lot of blood flow will happen, what happened to VTI will be more. Less blood will follow across LVOT, blood with VTI would be less. Ratio of mitral valve VTI versus aortic valve VTI will give you everything more than 1.3 is considered as severe.
In both the equations, sir, aortic valve VTI is in the denominator.
Aortic valve LVOT, both the equations are in denominator. Perfect. I'll remember this. Even I learned so many things from you guys. Is it learning on both sides?
Yes. Yes.
Okay. Any other things? Any other questions? Okay, before we break today, I want to announce something.
Exam.
Yeah, exam would be there, no doubt about it. What I was trying to tell you now, we have to finish up this course by 24th of September, before 24th September. And in this July, by 21st of July, I've got a lot of time, like almost 5 weeks are there with me, where we'll be taking up at least 2 classes per week. So if I go back and show you the program, So all of you should get ready in the sense now onwards, every week we'll have at least 2 classes so that in 5 weeks we completely finish up by 10 classes at least.
Okay, sir.
Yes, sir.
And offline, sir?
Offline is in October. Those who have opted for October and January.
So exam will be offline, right?
Online. Exam is online. Google based exam. You have taken up the exam earlier also.
Yes, sir.
So let me just share you the schedule. Why are you so afraid of exams, you know?
Sir, after it's getting anxiety.
Take a
So,
compose.
sir, doing a routine work is easy. Learning something new is becoming difficult.
You know how hectic my lab is sometimes. For almost, I landed back from America on 8th of this month, 8th of July in the morning. And today is 19th. For last almost 11 days, we have done more than about 400 echoes.
My God.
And those 400 echoes in 10 days, at least 30 to 40 echoes, 3 to 400 echoes. And approximately 60% echoes are not normal. Today was a respite after 11 days when we did about 20. So it's not that only like you say, like you are doing a practice. Look, I have to take my rounds. I have to take my OPD. I have to do my echo. I have to teach you and prepare for my next presentations. 2 presentations. I have to go to Manila in September to do my presentation. I have to go to Sri Lanka to conduct 2 days class continuously. So those are in pipeline. August, I'm doing an advanced skill training program for 4 days, 5 days rather. So that's why I said by August 22nd is a starting of that advanced skill trainings. So I want to finish your at least 8 to 10 classes before that time. Because that'll be Herculean task in those. We show everything live. I'll show you aortic stenosis live in advanced skill training. Every point we demonstrate in advanced skill training. We do not talk too much in advanced skill training. We just show the various points and salient features. That's all.
Yeah.
So you're not doing much more
That is
than
only for 5 days only, sir. Advanced course is only for 5 days.
advanced course is only for 4 days. That's
4
for live demonstration. Everything is live. Like suppose I'm showing you aortic stenosis, I'll show you all the points of aortic stenosis, including GLS, including transvalvular rate, including acceleration, ejection time.
Mainly the candidates are
Level 2. You should have a basic knowledge, not at your level. We don't encourage you to come. We want you to come only when you're good in echocardiography. You must have learned a lot of echocardiography already.
So then, sir, how will be the further schedule?
Further schedule. Good. Look, this is what I'm sharing with you. Today we have done a valvular lesions and a review of exams. And then after what we are going to do is we are going to have a systolic function and diastolic function possibly together. Next class.
When will be the exam?
Exam would be next week, most probably exam next week. I'll show you a live demonstration. I'll try to do a live demonstration from a machine or my software and show you all the lesions one by one and then take an exam next week.
So that session would be somewhere in between?
26th.
Demonstration.
Demonstration and exam together. And then next week, I'm going to club systolic and diastolic functions, then cardiomyopathy, followed by online demonstrations. And next week, like 2 weeks, we'll cover up all these things. And third week, we'll have a question answer session and followed by exams. And congenital heart disease, one class will finish up everything. And then right heart and pericardium will connect in 1 week, so that we are almost on line with our, before September, we'll be on lines. So 2 classes every week we are planning to take up. Next class will show you a live demonstration and we'll take your exams. 19 and 26. 26th will do everything.
So what will be the timing on 26th?
Timing of?
On 26th of July, what will be the timing of everything?
Timing, you tell me what's the timing? I'll try to show a live demonstration at 5 o'clock. Followed by exam at 8. Or I can start at 7:30 or 7. Finish my live demonstration by 9 o'clock. 9 to 10 is your exam.
That okay.
That will be
Live
okay.
So actually, there
demonstration
was
of
a
polyvalent
commitment on
regions
26th of July.
or
Live demonstration means either I show you by laptop or my machine, either of these 2 things.
but which topic? Valvular heart disease or systolic
Valvular heart
diastolic
disease.
disease?
We'll be talking about
Acha.
valvular heart disease.
Okay, and then exam on the same.
Same day.
Okay.
The demonstration would be recorded, no?
Exam will also be recorded, man. So you want 5 o'clock or 7 o'clock?
So 5 o'clock would be better.
7.
No, sir.
7 would be
No.
okay, sir.
7
5
o'clock.
o'clock, okay.
7
7
o'clock.
o'clock.
Sir, 8 p.m. sir.
There is a commitment.
7 o'clock.
7 o'clock. 7 o'clock.
Exam at 9 o'clock. 7 to 9 is live demonstration.
Okay, sir.
Okay,
Okay, sir.
Okay. All right. So shall we stop over here? Are we done or some question left?
Sir, we don't remember what we are for offline, matlab actual in the October. Can we change October to January? Is it possible? If we are,
You want to change? Have you booked for October?
instead of I don't know, sir, but we were thinking it was in October. It is for 2 weeks or it is 1 month, sir?
No. Hands-on is only for 4 days.
Only 4 days.
Only 4 days. Is like you'll drop dead in those 4 days. Only, it's not only.
And
The probable date for in October?
October is already locked. There is no seat available. Only those people who have booked for October is allowed.
So that dates are fixed for October.
The dates are already fixed. Just a minute. I'll show you tell you the dates. Give me a second. Hands-on session is not a simple session. You know, like you start at 9 o'clock in the morning, finish by 7 o'clock in the evening.
we have to stay nearby, sir. Drop.
We have a guest house on top of the same building and we have a good hotel nearby also. Hands-on are from 17th to 20th of October. That's first batch, those who have booked it, and some vacancies are available in the month of January. That is on 17th, 16th, 17th, 18th, 19th of January.
Many
But can
candidates
we-
sir, at a time.
Hello.
Usually you take
Pardon?
for 4 days. How many candidates are allowed?
We take 35 candidates. We have 7 machines, 7 instructor. Every instructor is more than 10-year-old. So 7 machines, 7 tables, 7 instructor, 1 table, 5 students. And we have classes like 9 to 10 in the morning class, 10 to 1 is hands-on, 1 to 2 lunch, 2 to 5 again hands-on, 5 to 6 any questions. People go up to 2 to 6. So everybody get a lot of chances to do echocardiography.
So then should we book the flight tickets or should we wait for the exam results?
Exactly.
You have booked for a seat for a hands-on already
Yes, sir.
for
Yes, sir.
October, January.
Yes,
For
sir.
October.
Okay.
October, sir.
But probably October soon.
So you should work hard to get through the exams, man.
Can we postpone, sir? If somebody want to try?
Yeah, why not? Why not? Everybody. This is a democratic country.
Okay. So what to do be done for that, sir?
Send
Postpone
an
what
email
about?
as fast as possible.
Okay.
People are lined up for October. I am thanking you to just postpone as many as you can.
Okay, sir. Okay.
Sir, what if I have a query, sir? I actually an unavoidable commitment on the next Sunday. So what if, like, if the by any circumstances if the exam is missed, what will happen?
Sir, I'm taking exam not on Sunday. I'm taking exam on Friday.
Sir, that's on Friday and on 26th only. That is really unavoidable. I was just praying, but you said that the hands-on will be also be there on that day.
Look, I can't say anything about that because the only thing is we'll mark you absent. That's all I can say.
Sir, one query from my side, sir. I have joined the class late. I missed one exam. What will happen?
It
The
all
first exam.
depends. You have to improve your marks in the next second, third, or fourth exams. So cover up for first.
Sir, even if one exam is missed, we won't be eligible for October.
Not that way, like not the question of missing one exam. The question is how much you have read over a period of time. I'm not saying that you missed the exam or something like that. Look, Neeraj, the most important thing of a life is true learning. I'll share you very important thing is I was working in America in 91. I was the first person in the department to open up that department. At what time? 6:45 in the morning. And I was the last one to get out of the department by 7:40 in the night.
Committed.
And I used to live nearby. I used to say, whether you pay me or you don't pay me, I'll attend all the calls. That was a learning, like what is the time for learning? What is the important thing is? I was an intern in one of the government hospital in Delhi. And my thought was, you give me anything, I'll come and do it for you. First 10 days, all the case sheets came, like 200 case sheets, 300 case sheets came. Sir, complete our case sheets. So we used to sit down and complete the case sheets. Next, the call started coming up, sir, hamara plural tap kar denge aap? So we'll do the plural tap. Then the call came, can you do our abdominal tapping? So we'll do the abdominal tapping. So much so, during internship, you tell me which we did not do. Like people used to leave at 4 o'clock in the evening. We were there in the hospital till 10 or 11. And whole day, what we'll do, we do 10 process after 4 o'clock. Some plural, some ascitic, some intra-arterial. There was a guy who was aspergillosis in the lower limb. So we used to put intra-arterial injection in the femoral artery. And then we used to press for a long time, at least half an hour, so that it does not bleed. And that gives you a lot of confidence. Believe my word, at this age, you give me anything, I'll do it.
AIMS Delhi, sir. You were in AIMS
No,
Delhi.
I'm not a scholar, I'm an average student, very average student. Below average.
No, sir. No, sir. Okay. But you were loved profession.
I like, is this devoted? You do either something good or you don't do anything. In my post-graduation in medicine, I was the worst student of my class. There were 40 students who were there, and people used to tell me that 13 will pass, then only he'll pass. I said, what's the problem? I'll come after 6 months. And I was one of the topper in my exams for the post-graduation. Every evening, I used to go for shuttle badminton at 4 o'clock. For 4 hours, I used to play shuttle badminton every day. But only thing is, when I was in the hospital, I used to be very attentive 8 o'clock in the morning till 4 o'clock. So you have to be focused, you know what you're trying to see. And same thing I'm telling you, all of you, just be focused, you know. At least do a practice of 1 hour of echocardiography every day. Just 1 hour. Give your lunch to somebody and practice on him every day for 1 hour.
Yes, sir.
Right.
Don't try, don't cry. Okay, let me stop it over here and we meet next week at 7 o'clock. So first I'll show a demonstration and 9 o'clock we'll take an exam.
Yes, sir. Thank you so much.
Take care. Good night, Shabaka. Stay safe.
Okay, sir.
See you next week.
Night,
Bye.
sir.
So we will write some mail for that. We will postpone for January, like that, sir.
Yeah, whatever you want to say, just send a mail to ecocourse@gmail.com.
Okay.
Do it faster because Rina is trying to make an arrangement for October course now.
Okay.
Because we have to communicate to each and everybody that you are eligible for ECHO course in October. And that's what she is planning to do.
Okay.
Night. Bye-bye.
Good night.
Night, sir.